Hello.
Hello.
Great. Well, let's go ahead and begin. We're still waiting on Jean, but we've got lots of questions that have been coming in. And let's go ahead and jump in. So first, one for you, Joachim. There was a question on the potential impact of either portal vein thrombosis or portal hypertension as it relates to decision-making for stem cell transplantation.
Right. Well, I cannot give you hard, absolute numbers, but our impression has been, and we are looking at that in a more systematic fashion right now, that patients with significant portal hypertension, and particularly with varices, gastric or esophageal, are at a higher risk from, quote, non-relapse complications of what sort? Bleeding being one of them, but also hepatic toxicity, and maybe less important, but obviously ascites formation with impact on drug PK data and so forth. As I said, I cannot give you absolute numbers, but one of our GI fellows has actually expressed an interest. We are looking at that right now to put more of a scientific twist on it rather than just observational data.
Great. Thank you very much. Next one I'll tackle is CPI-0610 available only via trial at this time? The answer to that is yes. As a non-approved agent, it would be solely through those clinical trials. For those that are excited about the drug, again, as this process works its way through, clearly if the phase 3 trials are as promising as earlier studies, the drug likely would become approved in the near future and then have much broader availability. If a patient, and the second part of the question was, if patient is allergic to Rux, can they be on fedratinib instead? The answer to that is yes. So fedratinib is another approved agent that individuals can be upon, and it certainly can be used potentially for individuals that were on Rux and then proved allergic to Rux in myelofibrosis. Not yet approved in polycythemia vera. Next, a question I'll put to Serge. I understand that Pegasus can modify, slow, or reverse fibrosis in some. Does Rux have the same potential?
It has, but it takes much longer period of time and not to that degree and not in too many patients. We look at the patients that were on ruxolitinib for 4 or 5 years. And I remind you, in clinical studies, the median duration of therapy is 3 years. So only minority goes to 4 or 5 years. And in those patients, about a quarter, so in minority, and then a quarter of them had a decrease in bone marrow fibrosis. And we did not really find any real clinical relevance to that finding, other than it was observation. And we don't really ask anybody to do the bone marrow biopsies as a measure of a success to look at the fibrosis grade in patients that are on any JAK inhibitor.
Great. Next, a question for you, Jean. Is thrombosis less of a concern in myelofibrosis than in PV? And if so, why?
That's a hard one.
I agree.
I'm actually, to be very honest, I'm not sure, but if you think about the biology of JAK2 and how that seems to be associated with thrombotic events, I certainly get a little worried. But that being said, I don't see the same degree of thrombosis in MF, but I would be interested in what some of my colleagues think.
I would say that in terms of the numbers are probably less, but they clearly can occur in myelofibrosis. So sometimes a bit of a misperception. I suspect the change in the blood counts are a partial driver, where the typical early proliferation of elevation of cells is probably a greater driver in the P-vera phase than in MF. Likewise, the location of thrombotic events may be somewhat different. Serge, what do you think?
Yeah, I agree with you. I had a question like that posted some years ago by a few fellows that came through the door, and there was no real good study specifically in myelofibrosis to that detail that would answer what is the number of patients among 100, for example, that would have it and what period of time. It's always concoction of the different patients messed up together with other types of myeloid conditions. Unlike in ET and PV, there are many more patients and you can follow them with more precision for many more years. So, but I agree with you absolutely that the thrombotic and bleeding events are present to a certain degree in myelofibrosis, and perhaps more so in those earlier proliferative phases of the disease.
Here's a question, perhaps get both Joachim and Gene's input on. Does a high-risk mutation drive the need for a transplant sooner, even if the other features, labs, symptoms, fibrosis, are all lower risk? Is the success, and there's a second piece, is a success rate linked to mutation status?
Go ahead, Jane.
Well, that's a tricky question because, I mean, I would say, first of all, if somebody's low risk disease, but they have a higher risk mutation, that is definitely not somebody I would bring to transplant unless there was an unusual circumstance along with it. I feel like with the mutations, they direct me to following patients maybe a little bit more closely or pulling the trigger a little faster. But by themselves, I think, Joachim, you said this in your talk, by themselves, they do not make for a transplant. I think the way I kind of look at it is it's sort of a gray area and a very moving thought process. And so it just would go quicker with those and maybe follow somebody closer.
Well, I agree. Also, well, most importantly, from a transplant point of view, we really haven't made a lot of headway in overcoming the challenge of those mutations, even with transplantation. So the risk that is assigned to them in the non-transplant arena carries over into the post-transplant course. So that's why I mentioned additional adjuvant, or however we want to call it, therapy, I think needs to be tested until we come up with a novel approach. But that would be my answer to that.
As a non-transplanter, I'll add, to try to frame this, because it is true, individuals can otherwise have everything seem very favorable, and then you have the one stray high-risk mutation off of an NGS panel, and it clearly causes tremendous distress.
So,
from my take, that is a concern, as Gene states, that the disease may behave differently than if that mutation was not present. However, what it does not give us is really a sense of time,
right.
Because we don't know does that mean the disease is going to be a big problem in 2 years, 5 years, or 7 years, versus if that wasn't present, maybe the disease would never be a problem. So I think it has to be taken in the context of everything else in terms of the picture, but it's only one piece of information, not the whole piece.
And sorry, just to add to that, maybe stating the obvious, I think it, in my opinion, makes a big difference whether we are talking about a primary myelofibrosis or a post-ET or post-PV fibrosis.
Perfect. Now, Serge, here's an interesting question. When you've succeeded in shrinking the spleen with a drug, where are all those immature cells going? Don't they have to go somewhere?
I guess they're not going anywhere.
They are circulating.
They're circulating, but you see, the JAK inhibitors are anti-proliferative, right? This is where the activity is seen. The spleen is smaller because cells do not grow. It's kind of a stop sign. The cells don't grow anymore. Now, of course, you can say this is not that simple because the blood cell count not necessarily drops when the spleen shrinks. And there is no connection between the degree of anemia or thrombocytopenia that can happen while you treat patients with the JAK inhibitors and the degree of the benefit, the degree of the spleen reduction. And you would suspect that if the spleen is making blood and is becoming smaller, then definitely you will become more anemic or thrombocytopenic, and that's not the case. So there is so much unknown here. There is so much unknown. When we started therapy with JAK inhibitors, for example, and to connect with the question about fibrosis, we all believed that the fibrosis in the bone marrow was because of the cytokines, the proteins that are produced in the bone marrow environment. And with the JAK inhibitors, they normalize from being very high, multiple of them, to normal within a month. But fibrosis, as we said before, doesn't go away in a month. It takes years. So we are learning as we go from the efficacy or biological activity of the therapies we are using. So the answer is no, they are not circulating, but the disease is still there, and disease still can evolve to acute myeloid leukemia, for example. So it has multiple facets here of the therapy and of the disease at the same time.
Wonderful. Joachim, a question. Is molecular relapse treated with DLI or another transplant or some other approach?
All of the above. I mean, there are data, particularly by the European groups, suggesting or indicating that if we pick up a sort of MRD, measurable residual disease, or recurrent measurable disease, if you wish, at an early molecular, when there is no hematological recurrence, those patients may respond very favorable to donor lymphocyte infusion. I think if the recurrence is hematologically apparent, those effects in our hands have not worked very well. We have then usually treated with some chemotherapy or, dependent upon the patient's condition, offered a second transplant. And as I indicated in one or two of the slides, that is in a proportion of patient an acceptable and promising approach.
Great. A question for Eugene. With transfusion dependence, I have already developed antibodies making transfusions more difficult. What are further risks from continued transfusions?
So with continued transfusions, the antibodies definitely are a risk that people can develop them. But the other thing that we worry about a lot is actually iron overload. So with each, unit of blood, there's about 250 milligrams of iron, and that adds up over time. And then what can happen with the iron is it can deposit in the liver. The heart is another place that's really affected, and can ultimately wind up with some organ damage. The ways to overcome that, to some degree, are iron chelation, but iron chelation agents also carry some degree of side effects that make them more challenging to use in terms of their effects on the white blood cells and on the kidneys and stuff. So, obviously, it's a real balance, because transfusing is very important to quality of life. I mean, trying to let people live with a hemoglobin of 7 is a real challenge. But on the opposite side of that coin, you can develop this immunity that can make it harder to find red blood cell transfusions, as well as the iron overload. All that being said, the iron overload takes a while to really clinically manifest itself. So, for example, if you're getting transfusions, multiple transfusions now, the impact on your organs is probably a few years away.
Great. Here's a question I'll go ahead and tackle. I'm interested in the question of tapering long-term successful PEG interferon and ruxolitinib. Stable bone marrow, 15 years, stable counts. I note the Europeans are continuing tapering or stopping therapy. It's an interesting question. I'll see what my colleagues have to say. At the current time, we tend to think of the therapies, ruxolitinib and MF, PEG interferon, etc., as therapies that are suppressive. If they're effective, the patient's doing well, you're feeling well, your counts are stable, you're not having progression, that can benefit from the therapy. I think we have limited reason to have confidence in terms of, the wisdom of stopping or tapering therapy. It's certainly something that can be explored, but I'd have to say that it is quite it certainly introduces uncertainty. You might destabilize the benefit that you have and have risk of progression or doing worse. There are examples from chronic myeloid leukemia where individuals in a very deep remission for at least a couple years of time have been able to be tapered from their medicine. And even in those individuals, the success rate's been about 40%. So although I certainly understand kind of the driver of wanting to get off medicine, we probably don't know enough yet in terms of what causes progression, and do you risk having disease worsening by doing so. But Serge, what do you think? You've treated about as many people as anyone.
For myelofibrosis, I would absolutely agree. Perhaps there is a role of discontinuation even of therapy in earlier disease phases like ET or PV, when they have a certain parameters achieved through decrease in molecular burden or bone marrow improvements, as Dr. Silver talked about this morning about. But in myelofibrosis, this is progressive disease by nature, and it's very, very unusual to have a patient like this question suggests of having a disease for 15 years and now thinking about stopping therapy or decreasing the dose or schedule. That is exceptional, anecdotal, I would say. So in a standard practice with the expectations of median survival being half of the 15 years, then we don't really even think about stopping. We are even happy with stable because of a lack of available therapies. So I would not consider this in myelofibrosis.
Wonderful. Any thoughts, Joachim or Jean, about stopping, particularly long-term responders to PEG interferon?
Go ahead.
I was gonna say I agree with Serge, especially for a disease like myelofibrosis, that I think that if it's being tolerated, it's worth continuing.
I agree, and as you referred to CML, I mean, even there with a much deeper response and a lot of experience by now, everybody still cautions against discontinuation, but there is a proportion of patients. I wouldn't do it in myelofibrosis. I agree.
Wonderful. And now there's a question here with a few different components as it relates to transplant. So maybe I'll break it up. So one, they say, it's my understanding that 25 to 40% of all transplanted MF patients die from the transplant or shortly thereafter. True or false? Obviously, I would say that's false, but how would you more accurately kind of frame, the variable risk with transplant, Joachim?
Yes, I think we need to break it down really into, firstly, risk groups as far as the disease is concerned. Secondly, risk groups as far as the patient's condition, comorbidities are concerned. If we transplant patients earlier and there is no significant comorbidity, the non-relapse mortality is in fact very low. It may be in the range of about 15%, and a few patients will relapse. This is what gives us in the most recent studies a survival in remission of almost 80 or around 80%. However, once we get to higher risk, to more advanced disease, let me put it this way, there is clearly more non-relapse mortality, organ failure, and there is a higher risk of relapse. Overall, whoever asked the question, it is correct that we have long-term survival in the very high risk group of only maybe 40%, so 60% of patients die from various causes, but it is a much smaller proportion in earlier stage diseases, as we discussed.
Wonderful. There's a couple other parts of up your alley, Jean. So one, what percentage of transplant survivors have a bad quality of life? And obviously you could just estimate this, but also what percentage of survivors that have a successful transplant, without GVH and live a long quality of life without relapse? So, again, if you were to think of kind of, best case scenario, realizing that there's several different kind of phenotypes, how many people have a good quality of life based on your studies, and what would you guys estimate kind of the percentage of folks where it's really a great outcome?
So I think in terms of quality of life and the data set that we looked at, the quality of life was actually very similar. Looking at different things like the MPN, SAF and stuff, you had very similar scores, both pre-transplant and post-transplant. But interestingly, when you asked people, do you feel better or not compared to how you felt before transplant, it was over 60% who felt that they felt better 1 year out from transplant as compared to how they felt before the transplant. And so I definitely think that some of the thoughts that the quality of life after transplant is very poor and everybody is not true. Now, that being said, I always try to break it down. It's hard to do a transplant consult because on one hand, you don't want to terrify somebody of transplant, but on the other hand, you really have to prepare for the worst. So there are a subset of people, and they're probably a lot of the people who are most vocal on blogs, who have had a lot of complications after transplant and continue to have difficulty, remain on medications and have chronic medical issues after transplant. But I would not say that's the majority, and especially after they get out further, I find the first year or two after transplant, depending on how severe their disease is going into it, can be very rough. But a lot of people really recover back into a very, very nice life. I mean, it's definitely something that helps keep us going as transplanters, is to see people do well. So I hope that kind of helps answer the question.
The people in our group who have looked at that question, Karen Zoralia and others, tell us by 2 years post-transplant, 75 to even 80% of patients have returned to a level of activity that they, as Jeannie just stated as well, would describe as comparable to or maybe even superior to what they were prior to transplantation. But there is among those a subgroup with prolonged persistence of chronic GVHD, which certainly impacts quality of life, and patients have sort of reset their rheostat and adjusted to that. I mean, one has to acknowledge that. There's no question about
it. I think there's one other question with that I don't think we answered. I'm sorry, I can't remember what it was now.
That happens.
Great. Here's a question for you, Serge. Any idea when leuspatricept might be presented for in myelofibrosis?
So leuspatricept is the medication that is given as injection under the skin every 3 weeks, and it is anemia drug. It improves the anemia, and it's approved for certain types of patients with myelodysplastic syndrome, or MDS. It's not approved for myelofibrosis, but the study that is underway, looking at its activity in multiple different subgroups of myelofibrosis patients that are anemic to different degree, shows in about a third of the patients to have a significant clinical impact. That means improvement in anemia. And particularly in patients who are on a JAK inhibitor and have transfusions. So that is the actual plan for further study, for a study that will possibly lead to its approval. And that is the patients, again, on ruxolitinib, on a stable dose that benefit from ruxolitinib on a spleen and symptoms. That's what the JAK inhibitors do, but are requiring transfusions. And these patients will then be randomized in a blinded way between the leuspatricept and the placebo to prove the point that this drug works. And so we will need this study to get going, I think, anytime now, and it will take 2 or 3 years. So if we are successful, that will be significant contribution to what we do in everyday practice, because we have JAK inhibitors for spleen and symptoms. We don't have any drug approved for anemia at all. And these are the 3 main problems: spleen, symptoms, and anemia. So we don't cover anemia at all.
So based on the observation, if I may ask it for my own education, based on your experience to date in non-study setting, or certainly not in a phase 3, the proportion of patients you would expect to respond is very similar to what we are seeing in MDS.
About 30% respond by the definitions, of course. There are definitions for
Various
the studies.
Right.
And there are benefits that means improvement, but not improving enough to call it a response, like with any other drug, right? So I think majority of patients have benefits, and about a third of the patients have an official response.
Right. Okay, thank you.
There's another question. I'll try to go ahead and answer this, but certainly welcome comment. So do you ever reach a point with a patient when you see that quality of life is steadily decreasing and you don't think further treatment will help? How do you make that decision? What do you recommend to the patient? Well, certainly it is true that there are individuals, sadly, that we do lose to myelofibrosis. Clearly, everyone on this webinar is working very hard to try to find alternatives to try to make that not be the case. I think there are times that, again, based on other illnesses, based on the strength of the patient, based on the therapies that have been tried before, that we may decide that another medicine is not necessarily the way to go. I think as all of us seeking to be healers, we still try to provide whatever comfort we can, whatever supportive care, whatever way we can to help that patient's quality of life in any way that we can. But yes, there's a time and a place to try other drugs. There's a time and a place for clinical trials. And sadly, there is sometimes a time and a place where adding another medicine into the mix, unfortunately, is not going to be helpful. Any thoughts? Sadly, we've all had to have these conversations with folks over the years, but any other comments?
I mean, I agree. I usually tell patients, at that point, they're often requiring blood transfusions and platelet transfusions. And we have the discussion that, well, you can do this as long as you want. Not often I find people know when they're done. And they say, okay, I don't want to come in anymore for these transfusions. I don't feel like I'm getting a benefit. And then you make sure that they're aware of hospice and other options that can help both them and their family through that difficult time.
I agree.
I agree, yes.
Next is the question, what percentage of transplant survivors have graft versus host disease? And maybe before I ask our transplanters to kind of comment on this, I will share with you, a true hope in that transplant really can be an amazing life-saving procedure, even with individuals who develop GVH or mild GVH. My boss, the president of UT Health San Antonio, is a haploidentical stem cell transplant survivor. Transplanted at MD Anderson. An amazing story, but a man in his 70s, again, who is as vigorous as anyone you would ever see, and has done incredibly well. So it really can be an amazing thing. And does he have some mild chronic health issues? Yes, but really does extraordinarily well. But Joachim and Jean, maybe break it up in terms of, in whom is, what sort of percentage of folks do you really see it being, a day-to-day issue versus more of kind of a mild issue, the skin issues, things of that nature?
Right.
I usually try to keep everything really simple because there's lots of different numbers if you look at different studies. And the way I look at it is if you have 100 people in a room, 50 of them are going to have some type of graft versus host disease. And about 10 to 15 of that 100 are going to have it to the point where it really does impact their day-to-day life in a more substantial way. It impacts quality of life. And so that applies both to acute and chronic. Now, different studies may show 40% or 60% or 70%, but I think that those numbers are kind of the breakdown that I give people in it. And usually when we have a room full of people, I like to have people do standing up and sitting down so you can get a perception of the number of them. But even so, I mean, there's lots of ways that we're learning to recognize chronic GVHD earlier, because chronic GVHD is probably the more troublesome of them just because it can persist, cause scar tissue formation, and persistent problems even once the inflammatory aspects of it are gone. But I think that, we are learning a lot about it, recognition of it earlier, and different treatment modalities. The one question that I'd forgotten earlier was long-term survival after transplant, which kind of ties into this. And there's actually a very nice study that was done by in the European group that looked at long-term survivors and people who were alive 2 years out from transplant without persistent disease, and actually found very nice long-term survivals in patients who've survived that long. So there's definitely a good long-term outlook if you can make it to that time point after transplant.
I agree. Let me add on just one or two comments. I tell every patient I see before transplantation that the likelihood of you encountering GVHD in one form or another at one time point or another is probably about 50%. But what has been nice over the last few years to see is that chronic GVHD definitely has the incidence of clinically relevant chronic GVHD has definitely decreased with the use of post-transplant cyclophosphamide. And I think importantly, although the data are still limited, but there are some publications now with, for example, with in vitro depletion of naive T cells, CD45RS cells, that a procedure that does not interfere with the actual transplant success, so engraftment has not been a problem. And if patients do develop GVHD, interestingly enough, it is generally limited to upper GI and responds much more quickly than in the conventional setting to the administration of steroids. So there has been true progress, and there are a lot of new agents currently being tested.
There's a couple of questions that allude to this, and I'll put it to you, Serge, perhaps to try to simplify the question. Basically, with the higher risk molecular features, does the variant allele frequency matter? Because again, some individuals are finding, stray 1%, 2% of ASXL1, what have you. Is that as serious as something that is more prevalent?
Certainly, this is the extension of the discussion we had before. Is the presence, just the mere presence of a adverse mutation, significant enough to do something about it? And I agree with the colleagues that that's on its own, it's not the reason to do anything different or send the patient to the transplant just because in a low-risk patients you have ASXL1. The extension of that is the question that you are asking: how many cells, to simplify it, are affected by that mutation in the sample that you get from the patients. And some patients may have multiple different mutations, and they may have different, what you call it, allele burden. So that types of work is underway, and I don't have a clear answer to that, but you would suspect that the higher the allele burden, there is more reason to believe that that particular mutation has to do something with the biology of the disease. If the allele burden is 1 or 2%, may not have anything to do with the disease. Maybe it's a passerby. Maybe it will go away in the next sample. Probably not, but just making a case for it, because we know that the healthy people, older than 65, for example, carry mutations, right? This is the clonal hematopoiesis of undetermined significance. That the healthy people without any disease may have a low grade of the mutations in their bone marrow cells. And so that may be what we do find in some patients with the disease. So not every single result, specifically those that are at such a low level, means that that has to do anything with the disease itself. So we have to be cautious in this particular area.
Great. Next, a question for our two transplanters. Are pets able to stay with you during a stem cell transplant recovery period, or perhaps kind of when?
That was a provoked question, no fair.
So I think it depends on what type of pet. Usually dogs and cats are okay. I tell them, don't sleep on the pillow. My cat would be devastated if I had to go through a transplant because he sleeps on my head. But, don't sleep in the pillow. so that your face isn't next to it. You don't have to clean up after your pets. You have to find somebody else to do litter box duty and poop scooping duty and stuff. But if they have like birds and snakes and lizards and stuff, which can be great pets, those are pets I do not want patients to be around in their post-transplant period.
Yeah, basically the same here. Yeah, use common sense.
Great. Well, we just have a couple minutes left. Why don't we each end on one thought from each of our panelists on something that you're perhaps the most excited about for making progress in myelofibrosis. Maybe Serge, why don't you go first?
You have experienced, I'm quite sure, throughout the day, the excitement that exists in our area of myelofibrosis in particular, because we talk about this right now, and the evidence of about, I would say, at least 8 to 9 phase 3 randomized studies that are underway in myelofibrosis. The phase 3 randomized studies compare something novel to something that would be standard of care, with the goal to develop those new medications for us to use. So I would suspect that in the next 3 to 5 years, we're going to have a number of new medications to help us in management of our patients with myelofibrosis. And that will reflect on my colleagues here that are specifically focused on a transplant. We may have then, because I don't think that medication will be curing anybody within 3 to 5 years, but controlling the disease, we may have more patients then eligible for the transplant, or on the other hand, delay the transplant for the future and not necessarily push it right away from the beginning. So it's quite interesting here how these things are going to develop, because I'm quite certain that new medications will be available, and then the transplant role will be affected either in positive or delaying the transplant for the future. So I'll give a chance to Dr. Deek to take over and see what's his view on these balances in the future.
I agree, Serge, with what you said, and I alluded to that when I spoke. I think that those developments will definitely impact the decision, particularly about timing, but maybe also the actual strategy to be used. And this is where I think the cellular therapies that are being developed will be very relevant. We don't really have yet anything truly in the clinic. There are studies going on with cellular therapy of one type or another against myeloid malignancies. And the one concern has been because of the deranged architecture, it may be difficult to access the relevant targets. But those developments are ongoing, and I think it may be a CAR T-cell type or T-cell receptor modified approach. One of our young colleagues is looking at neoantigens, particularly in these diseases, with some very interesting early preclinical data. So I think those developments are in parallel, and I think we will have to make them dovetail and integrate that in the overall management plan of patients.
Wonderful. Gene, it gets harder as you go because they take the easier ones, but what are you looking forward to?
Well, I'm looking forward to putting together all of these things. The data is so exciting with these new agents that instead of just, improving symptom burden, which is very important, but it may actually improve the bone marrow fibrosis, improve the clonal burden, et cetera. And I think that pairing some of these real benefits along with transplant is going to really be able to make transplant an even better option, and maybe even take away the need for it in some patients, depending on age and everything else. So I think that it's funny, there's like this whole period of time in a lot of these myeloid diseases where we were just studying the biology to understand the mutational landscape and how that all fit together. And now we're really seeing the fruits of that labor with all these new agents coming out.
And certainly I share the enthusiasm all my colleagues have for what's been discussed. And perhaps I'll tie it in with the Dr. Nangalia's talk, in that I think on the one hand, we're developing all of these new therapies. And as a cancer center director, have a sense of all of the types of new therapies being developed across both blood diseases and cancers that may end up having relevance for MPNs. But on the other end of the spectrum, I think we're gaining further insight as to why they develop and why they progress. And I think that's really key, because although we can try various therapies with the hopes that they might have an impact, until we really unlock why exactly do they progress, or it might be a series of different reasons why they progress, we'll be able to perhaps better tailor them to which therapies might be helpful for one individual, as well as perhaps develop new therapies that are not on our radar for really helping to impact the diseases. So I'll leave all who've attended today with a sense of hope. There is a tremendous hope for the future. There clearly are many individuals working around the world together, really as a team, as John Mascarenhas so passionately pointed out, trying to make a difference for you in real time to try to both alleviate the suffering that comes from this terrible disease, control the disease, and certainly for us to try to be able to cure the disease. So with that, let me strongly thank Dr. Palmer, Dr. Verstavchik, Dr. Deeg, and hand it back to Joanne to bring us to a close for this session. Joanne.
Thank you, Dr. Mesa, and thank all of you for your time and attention and your devotion to us and bringing us your wisdom on this entire day. And I really, really appreciate it. And I know all of my fellow patients do as well. So thank you and have a great weekend.
Great. Everyone, take care.
Bye-bye.
Bye.